Hey, listeners. Sadly, Paul and I were not around for this episode, but you have two great guest hosts, Doctors Leah Witt and Molly Hoybline, fantastic curbsiders who you've known for many years now, and they do a great job. Their guest on this episode on upper respiratory infections is Dr. Amber Bird. And now I would like to attempt a terrible pun. So just pretend Paul's here and that he is nauseated by how bad this is. So I called work this morning and whispered, "Sorry, boss, I can't come in today. I have a wee cough." He exclaimed, "You have a week off?" I said, "Really? Thanks, boss. I'll see you next week." Yeah, wee cough. Okay. Enjoy the show.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Leah Witt, joined by my co-host, Dr. Molly Hoybline. On tonight's show, we discuss upper respiratory infections, also known as the common cold, with our amazing guest, Dr. Amber Bird. In just a minute, Molly's going to tell you more about our guest and the topic. But first, Molly, can you remind the audience what we do on the show?
Absolutely, Leah. So happy to be here. And I'll be channeling Paul for this one. We are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We had a fantastic conversation with our guest, Dr. Amber Bird. She is a proud academic general internist who spends her time in her own primary care clinic as well as on the inpatient wards. She's an enthusiastic medical educator, having recently taken on the role of program director in the internal medicine residency program at Penn. She loves educational design and innovation, and her research interests are focused on the use of quality improvement research methods to address inequities in care delivery within academic primary care practices. When she's not working, you can find her passionately cheering on one of Philly's home teams.
Amber teaches us so much in this episode. We talk about diagnosis of common cold, often not even in an office visit, over-the-counter remedies, home remedies, when to reach for antibiotics and follow up, and even that we should be thinking about vaccination proactively when we have the opportunity to see patients in our clinic for common cold. So without further ado, let's get into it. A reminder that this and most episodes will be available for CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Welcome back to the show, Amber. It's so nice to see you again. And we're going to start with our rapid fire questions, our get to know you questions. So let's start by, I know you've been on the show before, so maybe your hobbies or interests outside of medicine have changed. Tell us what's new with you.
That is a great question. I didn't actually think about whether or not my hobbies had changed at all. I think that my hobbies are pretty much the same. I love all Philadelphia sports and running in my free time, although I found that in the years since I last was a guest on Curbsiders, I run a lot slower now. So now it's more scenic runs and less fast runs.
That's nice. There's a lot of beautiful scenery where you live.
Yeah, tons.
I'm all about the scenic runs. I tried to do a race once in college and I was like, this is terrible. I just want to go on my own and take my time, enjoy myself. Still get exercise.
I think if you make it to like a trail, then you can use the excuse that it's too steep, so you have to walk a little.
Yeah, exactly. Do you have a favorite failure that you feel comfortable sharing and what you learned from that?
Yeah, I think last time I focused a lot on like a medical-based failure, and I would love to highlight a non-medical failure, which is a DIY project that I tried to do on my home, where I thought it would be really easy to install some new trim along a garage door that was an automatic door opener. And I thought, I'm a doctor, I can do this. And upon finishing the trim installation, I hit the little button on the wall to let the garage door come back down. And it turns out a millimeter is a really big difference in trim. And I bent my garage door. It just got stuck halfway down. And what I've learned from this failure is that people have trades and skills that are really important, and you can't assume that you have those skills with no practice. And so it taught me a lot about proper planning and also in really investing in people that have the skills to do home projects. And that's not me.
I feel like I've been humbled in so many areas of life, and I always tell myself, like, I have other talents. It seems like I spent most of my time in medicine and maybe didn't develop those talents elsewhere. But
Yeah. And
yeah,
medical talents don't translate to all other,
no.
aspects of life.
Mm. Well, we have a lot to get into. Maybe we should just jump right into our case. We're so happy you're here to join us. Okay, so I'm going to start with our case. It's 8 a.m. on a beautiful Monday morning at Cashlock Northeast Primary Care Clinic. The sun is shining, your EMR inbox is overflowing, and your clinic schedule is starting off with an acute visit. So we'll be talking about Mateo. He's a 40-year-old man with no other medical problems, coming in with 4 days of nasal congestion and cough that's keeping him up at night and making it hard to work. So let's start with the basics: how you approach Mateo, how you define the common cold, and what does that visit look like?
Yeah, I think this is a really common thing in primary care. And I think of the common cold as almost synonymous with just what we call a viral upper respiratory infection. I think we use the term common cold for a lot of symptoms, but in my mind, I really think when we say that, we're saying we think this person has a viral upper respiratory infection, probably rhinovirus or non COVID coronavirus, although it could be any number of viruses that you might see on your respiratory panel, RSV, influenza, parainfluenza, enterovirus, adenovirus, choose your virus. And really, I think the hallmark in my mind is that these are more benign, self limited infections that generally are going to resolve on their own and are not of bacterial origin. So, really aren't things that we should be thinking about antibiotics for.
Thank you. That's a good starting point to bounce off of. When you're getting started with your visit with Mateo, are there certain things on the history or exam that help you really narrow down that this is a viral infection and that you're not worrying about other situations?
Yeah, I think sometimes when things are so common in outpatient medicine, it's hard to not just anchor right away and say, another cold, just going to give them the standard advice that I give every patient that comes in. And so I try to focus my history and physical on the things that would make it atypical. I think of rhinorrhea, congestion, sore throat, cough as kind of the hallmarks, the things that I'm expecting people to tell me. And certainly people can have variations of that. Maybe they have some headache, maybe they have a low grade fever. But I'm really not expecting people to have a time course that is much longer than a 5 to 7 day course in terms of the most intense portion of their symptoms. I'm certainly not expecting people to have weeks and weeks or months of symptoms. And I'm not expecting people to have a lot of constitutional symptoms. So, somebody who's coming in with fever predominant symptoms, I'm starting to expand my differential. Certainly, I'm still thinking about viral infections, but maybe I'm thinking about influenza or COVID, as well as other kind of secondary infections that might come from what may have started off as a cold. I also don't tend to think of lower respiratory symptoms. So, if somebody is coming in and they're telling me a lot of kind of dyspnea, shortness of breath, wheezing, then again, I'm expanding my differential because I think of that as kind of symptoms that are more suggestive of a more severe infection or complications of cold symptoms. So I think for me, timeline and then kind of the red flag or symptoms that really are kind of atypical symptoms for a cold are the things I'm looking for.
And what does that clinic visit look like in terms of physical exam and even thinking about testing?
Yeah. I mean, truthfully, I think for many of us, it might not actually be a clinic visit in this day and age.
Mhm.
A lot of times, this is a phone call, EMR message that you're responding to where you're getting some additional information. And so the exam portion may really be limited to just asking the patient to kind of report their symptoms. And truthfully, like, maybe I'm listening to their cadence of their speech or whether they can complete full sentences on the phone. If they do make it into the office, which I think is less common early on, so somebody with less than 5 days of symptoms without any red flag symptoms on that initial triage, they're probably not making it into the office. But if they do, I'm spending much more time in the history section, just making sure that I'm not missing some other, symptom. And then my exam is really focused on what are their vitals. I'm certainly like taking a look in their nose, taking a look in their mouth, and taking a good listen to their lungs. But I would say the vitals are probably the thing that are most important and helpful to me because a person with normal vital signs, so normal temperature, normal respiratory rate, normal heart rate, the likelihood that they have a more concerning severe infection is really low. And I think there's been data and studies on this before. And I think the sensitivity of all three of them being normal is in the 90% range. It's like 89%. And so that is really helpful for me if somebody's in the office and concerned. I'm not doing too much more than that in terms of exam.
You made such a good point that so much of this care is happening asynchronously on a My Chart message. So then, how are you parsing out who needs to be seen?
Yeah, I have a general rule of EMR messages, which is if we have to go back and forth more than 2 times, then I probably should just be talking to you on the phone or somebody should be talking to you on the phone because you're just asking too many questions to be able to get all the information that you need. But I think, to the point of what we just discussed, like most of the time, it's mostly questions that you're asking. It's mostly history. So, you're asking those alarm features, the duration of time that's been going on, the fevers, the lower respiratory symptoms. And if the duration of time is short, less than 5 days usually for me, and they don't have any of those more concerning symptoms, then I'm typically triaging them over the phone to more conservative management at home. And I guess I'll put like a little caveat in there and say that even the common cold can present really with more severe symptoms in somebody who is older or who has significant underlying comorbidities. And so that does factor into my thought process about whether or not I'm bringing them into the office. So if I have an older patient or a patient who has chronic underlying lung disease or chronic underlying cardiac disease, I'm probably bringing them in the office if their symptoms are kind of going on for longer, up to 7 days, or don't seem to be improving in those first 5 days of illness, just to make sure that we're not missing a more complicated infection. But I would say my rule for antibiotic consideration is 7 days. Like I'm not thinking about it for most people before 7 days. And I think many of my patients are now used to the idea that if they are calling me for antibiotics for something that sounds like a common cold, then they have to hit that 7 to 10 day mark and come into the office for an exam before I'm ready to hand over an antibiotic.
And say you saw Mateo, he did make it into the office, even though he's healthy and pretty young. And his vitals are normal. His lung exam's reassuring. He looks uncomfortable just because he's so congested and coughing a lot, but otherwise he's looking pretty good. Who would you think about sending viral respiratory testing for? Is that something that you offer in your practice, and who should be offering that?
Yeah, we do offer that in our practice. I think there's 2 big types of respiratory viral panels that we have. We have the kind of complete respiratory viral panel that you might think of on the inpatient side, where you get a swab and then there's every virus under the sun that gets reported on. And then we actually have seasonal respiratory panels that are narrower in focus and really are just looking at influenza, COVID, and RSV. I will say that, assuming I'm in the outpatient world when I'm seeing Mateo, because he's young and healthy, I generally am asking myself 2 to 3 questions. The first one is, again, back to timeline, like what's the timeline of symptoms? And in this instance, I'm using it kind of in the reverse, which is many of these tests are going to inform my thought process on how I'm managing these patients if they have something like influenza or COVID. And so they need to be within a window where I'd actually consider treatment. And so on the earlier side, so if Mateo was coming in and this was day 8 of symptoms, I'm unlikely to order respiratory viral panel just for diagnostic reasons. I will say the second question I would ask is, what is the severity of the person's underlying health conditions? Because that changes my thought process on how I'm managing their viral infection. So as an example, Mateo is young and healthy, but let's say it's Mateo's grandmother who's 80 and has chronic COPD and has had influenza type symptoms for 5 days. It's not in the standard window that I typically think of using something like oseltamivir, but the fact that she is higher risk with significant underlying comorbidities, if she was still symptomatic, doing that testing might actually inform me of reason to treat with oseltamivir. So I think I'm asking about the timeline. I'm asking about myself, like what is the underlying conditions for this patient, and how would this testing really change my management? So Mateo wouldn't get tested probably if he was coming in to see me. And I think the majority of my outpatients are generally not getting tested because I don't think it clinically changes my management. I think we all work in Cashlack Northeast Clinic. And so certainly testing for COVID or influenza may affect, the ability for healthcare workers to return to work. And I would defer that to, what the guidelines are at the hospital.
I like that framework of using testing to guide decision making. Basically, if you're out of the treatment window, then there might not be a reason to test. Would you, since we talked about so much care happening asynchronously by my chart or by telephone, would you be telling him to test for COVID at home?
Yeah, I think in reality, yes. I think that this happens so much now. And I think we are still in a window period of COVID where we're trying to figure out if it's going to become kind of like another common cold, but there's still more implications for how we think about isolation and return to work. And so for most of my outpatients, if they're calling and they have cold symptoms, the most recent strains of COVID tend to present fairly similarly to a common cold. And so oftentimes we're advising them to test, but mostly so that we can give recommendations on how they should manage being in public settings.
Okay, great. Should we move to treatment? I'm really excited to talk about some symptomatic treatment questions because this is what I get asked all the time. And I feel like the drugstore aisle is sort of a black box for me. As a physician, as a patient, I feel like I've explored it plenty. But so Mateo, he's trying to work. He wants some symptom relief. There are many different options. Are there any pharmaceuticals that over-the-counter medications or medications that you'd be prescribing for his symptoms, which sound like they're primarily cough and nasal congestion for his symptom management?
Yeah, I think it is hard to not give recommendations for things to do when people are feeling unwell. And I think I try to take a really hard stance against using antibiotics. And so then I feel even more inclined to try and offer something that is going to give patients some relief. I think the reality is effectiveness for most of these medications is really in the eye of the beholder. Like, there's going to be a different response for each patient or perceived response to some of these medications. And overall, the data that we have is not overwhelmingly positive for any one agent. I think the two things that I probably am grabbing for most often if somebody is having typical common cold symptoms, so congestion, rhinorrhea, I'm usually grabbing for something like a decongestant that is a nasal decongestant or a combined decongestant and antihistamine, which both are available over the counter.
Like oxymetazoline, is that what you're thinking? What you're talking
Yeah,
about?
so if nasal congestion was the predominant feature, then something like oxymetazoline. If they preferred an oral agent, then I might be talking about like an antihistamine like cetirizine or loratadine in combination with like a pseudoephedrine. Mostly because I think that they tend to have more symptomatic relief, and the data that we have suggests that it's a smaller number needed to treat in order to get some symptomatic benefit. So for combination antihistamines and decongestants, oral antihistamine and decongestant, the number needed to treat is between 4 to 6 patients to get some symptomatic relief. So those are generally agents that I'm thinking of. And then in general, if somebody is just having more vague rhinorrhea and congestion, or maybe they have a reason that I don't want to grab for an oral decongestant, I might actually just use any type of nasal spray. So whether it is fluticasone, like an intranasal corticosteroid, or nasal saline, or a neti pot, something that is creating kind of a lavage of their nasal passages, I think also can offer some symptomatic improvement. I think, again, the data is mixed on the patient-reported symptom benefit, but there is a suggestion that it improves symptoms for patients, probably doesn't drastically affect overall symptom duration. I think on the order of maybe a day less of symptoms, a day and a half less of symptoms, depending on the patient population that you're looking at. But they're pretty low risk, pretty well tolerated. And if it provides some symptomatic benefit, then I'm usually offering that.
Molly, I'd love to hear your practice on this. My practice with oxymetazoline has really evolved because I used to think and tell people that this is not a good medication. You're going to become reliant on it, but it really can be very beneficial in the short term. And as long as it's used appropriately for a short amount of time, and then spare people of the systemic side effects of oral decongestants. I don't know what you think, Molly.
Yeah, I usually offer people kind of a menu. I mean, I have a dot phrase that's sort of, if you're okay with nasal sprays, I would suggest these. Some people hate putting things in their nose, and so really would rather have a pill. But yes, from personal experience, I would say the oxymetazoline just really opens things up pretty abruptly, and can be definitely symptom relieving. I mean, in terms of the 1 day lasted symptom relief, that's kind of what we're looking at in terms of oseltamivir, and that's a expensive FDA-approved medication. And so, I think if someone can spray some saline in their nose for a week and that helps them feel better by a day, that's probably worth it.
Yeah. And I think that to your point of patients have preferences on what they prefer or don't prefer, like whether it's swallowing a pill or using a nasal spray. So much of this is a little bit of like catering to the preferences of what your patient has for how they're treating their symptoms, but then also like what their predominant symptoms are too. I will say the nasal sprays, I also always have to remind myself, and I spend a lot of time in our resident clinic, like to make sure that people actually know how to use the nasal sprays too, because you'll run into a lot of people who maybe have not had benefit, but have not really learned nasal spray technique and probably are not effectively getting the medication into their nose.
We interviewed Dr. Fadukba also at Penn about seasonal allergies. And she said, if you taste it, you waste it. So she had a really good recommendation for pointing the spray bottle to the ipsilateral corner of your eyebrow. So that I always think about that if I use a nasal spray. Do not taste it. You don't want to taste it.
And I think we've talked about it on the Curbsiders before, kind of about the new data around phenylephrine. And I think those products are still available on the shelves, though. Am I correct on that?
Yeah. So
Or have they been taken off?
I don't think they've formally been taken off the shelf, although I do think that they are harder to find. So the FDA statement on the lack of efficacy for oral phenylephrine, I think, has really drastically reduced the availability of it, which is probably appropriate. If it's not effective, patients probably should not be using it. But there was recently an FDA statement on, the use of intranasal phenylephrine still potentially being an option because it wasn't evaluated in the studies that looked at the efficacy of phenylephrine that the FDA reviewed. So I generally tell patients if they're getting a decongestant that they should be asking the pharmacist for pseudoephedrine. That's generally my recommendation. So we tend to steer clear of phenylephrine.
Yeah. And I think that covers congestion pretty well. What about cough? What is sort of your go-to when patients really complain about a cough?
Yeah, cough is a tough one because I think it is really, really bothersome. It tends to keep people up at night. And then once people are tired, then, they feel even worse. And then the cough tends to linger. And I know in the beginning, we discussed how, common cold symptoms, really 5 to 7 days is kind of what we think of, but a cough and a post-viral cough can certainly linger for days to weeks after. And so it tends to be something that you're getting repeated calls about. I use dextromethorphan for adults. The efficacy is probably like meh. It's not the best. I don't think it's going to decrease symptom duration meaningfully for patients, but it does improve symptoms better for adults than it does for children in terms of the data. And then there is some data to suggest that guaifenesin can help a bit with the more reactive cough that patients can get in the post-viral period of their cough. So I certainly will think about both of those agents. I think the one that comes up all the time is benzonatate or Tessalon, and whether or not that really is effective for cough. And I think the data is really, really mixed. I would be lying if I said that I never prescribed that for patients, because I think the reality is many times patients will try things over the counter and they don't get adequate relief and they're calling back with a cough. And so it feels really empowering to be able to prescribe something. And so since it's a prescription medication, a prescription antitussive, it feels like we're doing something. But the data for benzonatate actually suggests that it's probably not as effective as we make it out to be. There is some data that suggests if you take benzonatate with guaifenesin, that actually may lead to better symptomatic relief of cough. But that data also suggested that guaifenesin alone led to better symptomatic relief of cough. And so there's a chance that it might be more guaifenesin effect than benzonatate.
Yeah, I also sometimes prescribe benzonatate because you're right. It does. People often will want something. I'm trying to avoid antibiotics, and it feels like you're doing something that feels relatively safe. I learned recently when I was researching this medication that there is a risk in kids, and most of these medications, we're not talking about kids. That's a different set of recommendations, but the medication, it's peripherally active too, and kids can overdose, especially less than 10 on benzonatate. So you definitely have to protect that medication if you've got kids in the house. And I guess it works. I researched this recently. It's like a topical anesthetic on respiratory stretch receptors. Since I am also a pulmonologist, I see a lot of people with cough that's related to an exacerbation sort of the chronic lung disease. Maybe they've got asthma or COPD and bronchiectasis. I try to remind them that cough is a protective mechanism. So we don't want, in many cases, to completely eliminate the cough, but have to respect that people will be up all night coughing, and that is super disruptive. And I think that's why so many of our cough medications over the counter are these PM medications. What are you seeing or recommending with the cold and flu PM medications?
Yeah, that's a great question. I am a staunch believer in avoiding at all costs combination medications that you can get over the counter. And the way I try to counsel patients is to say, you don't want to be taking medications you don't need. And most of the time, the medications that are over the counter that are these combination medications tend to have numerous meds that aren't actually going to do anything for their most bothersome symptom, whether it's acetaminophen or dextromethorphan or phenylephrine in a lot of the combination meds. And so I really try to focus on what are the specific symptoms that you're having and what's a specific medication that's going to try and help to alleviate that symptom. I think most of the PM medications really use first generation antihistamines, which if you think about the medications that are going to have the most side effects for most of our patients, those are the medications. I think about urinary retention. I think about cognitive effects on elderly patients. I think about the drowsiness. Obviously, that's the side effect they're trying to get, but just things that are really not going to be beneficial in the long term. So I try to avoid them.
And I don't know if you guys have ever gotten this question, but I've had a number of patients ask me, they say guaifenesin is marketed as an expectorant and dextromethorphan is marketed as a cough suppressant. For trying to loosen the mucus and get it out, is it okay to suppress the cough at the same time? And it sounds like from the Tessalon data, you were saying that it probably does work in combination, but is there any concern about combining?
Yeah, it's so interesting. The Tessalon data, I will tell you, if you just want a fun study to read, the study that looked at Tessalon looked at benzonatate versus guaifenesin versus combination benzonatate and guaifenesin versus placebo in adults who were presenting with acute viral upper respiratory infection. And then to Leah's point of benzonatate being kind of an anesthetic to the stretch receptor in the respiratory syncytium, they exposed people to capsaicin because it would trigger that cough reflex and then try to measure cough reactivity. So again, probably not truly a symptom-based study that is perfectly applicable to how people are living their day-to-day life. But that showed that there was no significant improvement in the benzonatate alone group, but some in the guaifenesin alone and some in the in the combination benzonatate and guaifenesin, nothing that included dextromethorphan. I think physiologically, I could think about a lot of reasons why you might not want to use them both together, but I don't know that there's any data that really supports not combining them or any particular danger to using them or increased risk of secondary bacterial infections from using them together in like average risk adults. And so I don't counsel people to avoid combination use, but I do generally try to ask them the question of what they're trying to do. Are they trying to suppress a really bothersome cough at night? Then I'm probably recommending dextromethorphan. And if they're saying I'm having really, really thick mucus or I'm having trouble coughing up my mucus, then I might be saying guaifenesin. I don't know that that's really evidence-based. It's more just trying to meet them where their symptoms are.
How about inhalers for people who don't have lung disease, or maybe they do, and this is the first time that they've been diagnosed, but really like people who are otherwise previously healthy? Are you prescribing albuterol, ipratropium?
Yeah, I am not typically. I think that there is a lot of conflicting data on the benefit of inhalers in patients without underlying reactive airway disease. That's not to say that if I have a suspicion that somebody may have undiagnosed reactive airway disease or that somebody might have particularly bad lower respiratory infection where they really are having like bronchitis type symptoms, that I'm not considering them in that setting. But I would say for most patients, especially with upper respiratory infections, I'm not grabbing for inhalers. And I don't know that there's great data out there to support their use. But you also are a pulmonologist. So if you have a different perspective on that, I'd love to hear it.
No, I think that's right. But I do try to keep in mind that a lot of people with reactive airways disease, the only time their symptoms really manifest or are, diagnosed is when they have a URI. So just as you talked about, if the symptoms are going on longer than 5 to 7 days and the cough is really severe, keeping them up at night, then I think that's when you start to think about what else is going on. And is there something that this is unmasking?
And I think it's probably a good reason to push for that office-based exam if you haven't done it already, because being able to really listen to somebody's lungs and hear, are they having wheezing? Do they have symptoms that they're telling you that sound more lower respiratory or helpful in that setting? And I guess to your point, I will also say that I am more likely to be prescribing inhalers for my older patients with likely underlying lung disease that has yet to be diagnosed yet. And I'm seeing that they have a viral URI, but it's triggering maybe undiagnosed COPD exacerbation or something like that. So there are times when I'm thinking about it.
Yeah, and maybe we'll get to this a little bit more in the counseling, but I think, so helpful to give patients that anticipation. I'm always a little surprised because I'm like, you're 40. I'm sure you've had many colds in your life. How do you not know this already? But I think they really do benefit from sort of hearing that this cough may last 4 weeks. That could be normal. You should be feeling better, but the cough often is the last thing to improve. And that doesn't mean that you necessarily need more treatment. It just unfortunately means more time.
Yeah.
I think if we're done with over-the-counters medications, I want to talk a little bit about home and traditional remedies. Some of these are over-the-counter also. Are we okay to move on to that? Yeah. I'm excited to talk about this because this is what all of my family members and friends are talking about, recommending to me when I'm sick. Did you try honey? They'll be like, I know you're a doctor, but did you try this? And I guess this is another thing of the many things. It's like as you go along in practice, you become more humbled by all of the non-traditional medical treatments that really do have some effectiveness. I mean, I remember when I was a kid, my mom always gave me 7-Up. And to this day, it's like I think of that as something that's very comforting when I'm sick. So I'll just give you that broad question of like, what evidence are there for traditional or home remedies like zinc, soup, chicken noodle soup, honey, vitamin C, menthol? There's a wide range of things that you can recommend.
Yeah, I will say that all of my knowledge about this probably happened after my medical school and residency training. And I think that's to your point, Leah, that it's what people ask about. And then you want to feel like you have some knowledge about what is actually going to be helpful or not helpful to them. Honey is the first one that you mentioned, I think. And honey actually is one of the things that has some data behind it. more so for children actually than for adults. But there is some data out there, smaller studies, that suggest that honey actually can have significant symptomatic improvement for children. Interestingly, like one of the better studies, it was focused on buckwheat honey, which I had no idea what that was. So I had to like look it up, but I think it's just honey that is a little less sweet than traditional honey. So maybe not as enjoyable to use, but certainly could be helpful. And then the other like three that probably come to mind for me that I'm sometimes talking to patients about would be tea, zinc, or vitamin C. And they're all a little different. So tea, traditionally I would just say drink some hot tea. But if you actually look at what evidence is out there, it actually is probably more so for green tea. And green tea has kind of a component of it that can actually probably in all comers, not just upper respiratory infections that are viral, but all upper respiratory tract infections. There's some data that suggests that the consumption of green tea can lead to a decrease in duration and severity of those illnesses. Now, I can't say how much green tea is enough to do that, but certainly it wouldn't be harmful for patients to do. I think that vitamin C comes up a lot. And vitamin C, I would say that the data is probably strongest for prevention. So thinking about taking it in individuals who are at risk for common cold and who are specifically in physiologically stressful situations, whether that's like the activities that they're doing or the temperatures that they're exposed to, like cold environments. And it might just decrease the severity of infection or the likelihood of infection. Again, really like probably not the strongest quality of data, but low likelihood to cause harm to patients. So if somebody's trying to prevent illness and really wants to take vitamin C, I think that that's fine. It's a wide dose range. It's 1 to 6 grams per day, but probably not as useful once somebody already has a cold. And then the one that might actually have some evidence behind it is zinc. And so zinc, there again is some mixed data on some studies that show more of a benefit, some studies that don't, but it may shorten the duration of symptoms for patients with common colds by about 1.5 to 1.6 days. So to Molly's point earlier, very similar to what you might see with oseltamivir for somebody who has influenza. It really is related to the quality of the zinc lozenges that people are using. And so something that is actually zinc as opposed to a lot of sugar and other additives is probably going to be of more benefit. And the only real comment I can say is that we don't know how much you should take. We just know that if you take 100 milligrams per day, that's probably the max benefit. Like if you go above that, you're not getting more benefit for using more zinc lozenges, but somewhere in the range between, 20 to 100 probably can offer some benefit. So those are kind of the ones I think about. I selfishly looked up coffee because in my mind, if I could drink coffee and be better, that seems like a great solution. And there's absolutely no evidence that coffee has any beneficial effect on the common cold. So sad for me.
Man.
So no evidence of harm.
No evidence of harm. No evidence of harm. And I will say that I to the point of like soup and popsicles, there is no data on soup or popsicles, but there's probably, again, very little harm from either of those. So I think if your throat is sore, a popsicle sounds great.
Is there anything else that you suggest to people, Molly?
I think the only other one that we haven't talked about yet is like lozenges. So, cough drops, menthol or honey or.
What about gargling salt water? I was just looking at this amazing AAFP review that we'll link in the show notes of treatment of the common cold, and I don't see it there, but anecdotally, I think gargling with salt water can help a sore throat. Do either of you recommend that?
I don't typically. I mean, I suppose if somebody has very severe like pharyngitis symptoms, which truthfully, even like severe pharyngitis, I don't think of as a predominant symptom of a common cold. Certainly people can have some sore throat. But in those settings, I'm oftentimes talking about analgesics like NSAIDs for symptom relief. I don't know that there's any strong data for saltwater gargles, but I'd love to be proven wrong.
And then I think we didn't talk about like ointments with menthol, eucalyptus, and there is a little bit of evidence for children. So again, something that probably doesn't cause harm as long as you're not like putting it up your nostrils. That could maybe cause a problem, but a topical application could be beneficial, maybe comforting.
Yeah. I think that kind of gets back to the point of, again, like efficacy of any of these medications is in the eye of the beholder. And if I oftentimes encourage patients to try things that are not harmful and find out what works best for them, especially when we're dealing with things that may not have a overwhelming benefit. So thinking about like the types of lozenges that work best to relieve their symptoms.
Mm-hmm. Yeah, there are so many remedies that are like cultural based on family traditions. And I'm sure the next time we do this episode, we'll have more ideas from things that we've seen our patients do.
Yeah. And maybe that soup study will come out.
Yeah.
What about like targeted antivirals? When are you thinking about prescribing those to patients?
Yeah, I'm generally thinking about them based on patient. It depends on the antiviral. I guess that's the starting point. So,
so maybe we'll talk about influenza first.
Yeah. So influenza, I'm generally thinking about it based on patient population and timing. Similar to what we said earlier, I think for me, some of it is going to be patient preference. Like, are you interested in taking a medication that might limit your duration of symptoms by a day, day and a half? Or are you more inclined to like avoid medications? Like Mateo, for example, like average risk individual who I'm not worried is going to have severe complications from their influenza. If they're coming to me within 48 hours, they have syndrome that's kind of consistent with influenza, or I'm doing testing and confirming that they have influenza and they really think that that day and a half is meaningful, then certainly I will prescribe that medication. For flu, I also think about, are they somebody who is living in a household with somebody who's really high risk? So I take care of a lot of families who live in multi-generational houses. And, if I have a young, healthy person, but they're the primary caregiver for their elderly family member who has a immunosuppressing condition or chronic lung disease, I may actually consider prescribing Tamiflu in that situation to reduce the risk of exposure to household contacts. And similarly to how I would think about people who are healthcare workers who might be around individuals who are higher risk. But generally, I'm recommending it for high risk populations. So pregnant women, individuals who are elderly, individuals who have underlying health conditions who are coming in with symptomatic influenza, then I'm prescribing oseltamivir in that situation. Generally, I'm trying to restrict to the less than or up to the 48-hour mark. But for people who have real underlying conditions, really advanced lung disease, they are immunosuppressed because they're on chemotherapy, then I'm extending it beyond that 48 hours if they're symptomatic.
And that sounds just so hard to have a patient reach out within the first day or two. And, you feel like you have a high enough suspicion that they have influenza if you're, talking to them over the phone. Do you kind of keep track of influenza rates in your area with any particular resource, or do you use that to help guide you?
Absolutely. Yeah. I think that, influenza is certainly something I'm not thinking about in the middle of June when we don't really have circulating influenza. And so it's really helpful for me to think about the local rates of infection. And I'm fortunate in that I live in a large city where the public health department reports that regularly. So there are weekly reports on influenza incidents. And that can help guide, one, my differential for patients, but also the way I think about testing and treatment. So I certainly use that. I will say, obviously, there are other infections where that's much harder to track. Most of our common cold viruses, we don't have great data on. And truthfully, COVID, I think every other year has been slightly different in terms of when we're seeing the peaks occurring. So I use that data if it's available. And I think it's helpful for me, more so for thinking about testing or empiric treatment without testing.
And that's just through your local public health department, that you don't know of any national resource or?
Yeah, not any national resource that I use. Although I do think that the CDC reports regularly on like the trends in terms of influenza infections. I find that the local data is just more helpful for me to make practical decisions.
So we've talked a lot about antibiotics already, but I want to talk about it even more. Both when you think about starting antibiotics, what are the symptoms that make you consider it? And then also, what do you tell patients who you don't think need antibiotics so you can maybe avoid that feeling that they came all this way, they made an appointment, they did a copay, and then you're sending them home without what they maybe wanted.
Yeah. I think that it's really hard to tell people that they don't need antibiotics when that's what they're coming to see you for. But I think it's really important. So I think generally in those, if they've made it to the office and we're having that conversation, then I am spending a good portion of the visit counseling on just what I think is going on, why I don't think it's a bacterial infection, and why I think that using antibiotics actually wouldn't be helpful and may actually be harmful. I also think that it's really helpful to create a space where patients don't feel like we're shutting the door and that's it. Because I think a lot of people worry that they're going to leave that office and then they're not going to feel better and then they're going to have to go through the whole process again. So a lot of my counseling is anticipatory counseling where I'm saying, right now, I don't think you need antibiotics. But if your symptoms were to change, where you start to notice fevers or they initially get better, and then after a few days, you're noticing they're worsening again, or you're really all of a sudden noticing severe pain on just one side of your face, or new shortness of breath or a fever that you didn't have when your symptoms started, I want you to reach back out. And those are the times where I'd start to think about, could this be a bacterial infection or do we need a different treatment approach? And so I do try to kind of empower them to feel comfortable reaching back out if things change. And I do explicitly state a timeline. So I say, like, today is day 3. I expect that you're going to have these symptoms for at least this week. And at the end of the week, they should be getting a little bit better. So if at the end of the week they're not getting better and they're actually worsening each day, I need to hear from you and try to give them kind of a realistic timeline. I do also, as scary as it sounds, tell people that they might expect a cough to last for weeks because I think knowing in advance actually can be reassuring. And so I try to fold that into my anticipatory guidance. I don't think it makes everyone happy. I think there's still people who certainly leave and they're very unhappy. But I really try to avoid the like antibiotic in the hand to use later or the unnecessary antibiotic prescription.
This is also why I think getting comfortable recommending some of these over-the-counter or home remedies, especially the home remedies with limited harm risk, is so important so that people feel like they can do something. And I feel like that's where I've turned a lot of my attention recently because I think earlier in my training, maybe I was a little bit more cavalier, like, it'll be fine, it'll go away. And then people end up feeling maybe dismissed or like there's not much that they can do. I don't know if any of your practices have evolved, Molly, or like, what you all do about that.
Yeah, I would say in my experience, and maybe it's working at Cash-like Bay Area, a lot of people are very happy to hear that they don't need antibiotics. There's a lot of attention on gut health and, anxiety about antibiotic resistance and that kind of thing. But I certainly do have those patients who say, I know my body, every time I get this cough, I know it's bronchitis. I know I need that azithromycin or else I'm not going to get better. And those are really hard conversations to have because they say, well, I know when I start the azithromycin, my cough's going to get better. I'm like, well, maybe it would start getting better anyway because you're on day 7 now. And but it can be challenging.
I also think this is a reason why, as hard as it is, I try my best to see or speak with patients who have these symptoms in my own clinic if possible, because I do think some of the like consistency of how you approach it can be really helpful. And I think there's a lot of variability in how people approach these symptoms. And so I think like being able to consistently provide a message and to build that trust and rapport where patients feel like comfortable knowing that, hey, if I really am not getting better or if things are really going a different way, like I trust that I have somebody who's going to hear those symptoms and treat them can be helpful. But I also will like be very specific about the over-the-counter medications, to your point, Leah, or like the home remedies, to say like, these are the things you can try. And if it's not working, then you just reach back out.
All right. Well, Mateo wants a little bit more anticipatory guidance. So he's got older parents with health issues. He's got a 2-year-old. So what would you tell him about risk to I guess we can start with just his family who's older and maybe has health problems?
Yeah, by the time Mateo's contacting us, he's probably already had some exposure to his family members, and maybe even his young child was the initial exposure for him for this illness. So many times, what I am discussing with patients is the times when they are most contagious. So usually that starts even before their symptoms start, so the day or two before, and then the days when they are most symptomatic, typically at the beginning of their infection. So I think of it as like the first 3 days or so of their infection. But the reality is can be contagious for a really long time. They can be contagious for upwards of 2 weeks, depending on their immune status, depending on the infection. And so this is challenging to me because I think that there's no easy way to counsel people on absolutely like no risk of passing a virus to another person. Plus, we know that some viral infections are just more contagious than others. Influenza and COVID are both viral infections that we worry about, but COVID is actually much more contagious than influenza is. And so much of this is dependent on the patient and how concerned I am about the people that they're going to be in contact with. So if Mateo's family is mostly healthy and he's already starting to feel a little bit better in the first few days, I'm probably telling him, for the first 2 to 3 days, practice really good hand hygiene. Try not to like cough or sneeze directly on your family members. If there's somebody who is really immunosuppressed in the family, maybe try to isolate from them for those first 2 to 3 days. But then after that, as long as your symptoms are improving and as long as you're not persistently febrile, it's probably okay to be around family, and you should just continue to practice good hand hygiene.
And what about kind of guidance around what's normal in terms of colds? So Mateo's 2-year-old is in daycare. Leah, maybe you're experiencing this currently. He just feels like he's been sick, like for months, and he just keeps getting those. When do you start to worry about recurrent colds? And like, how do you counsel patients about what's sort of a normal number of colds to get a year?
Yeah, Mateo's in trouble because he's just going to be exposed a lot for this year. The like average number is so variable based on exposures. So, for an average adult, we think 2 to 3 colds a year is normal. But that's completely different than what we might think of in children. And so infants can have up to 11 colds in a year. Preschool age children can have up to 8 colds in the year, and that's completely normal. So if you are a new parent with a new infant in daycare where they're getting exposed to lots of viruses, maybe up to 11 is normal. Getting a cold a month wouldn't be completely out of the realm of normal. I think that we expect that somebody with a good immune system should build up some immunity to some of those viruses as they get exposed over time. So I might start to get concerned if somebody doesn't have a new risk factor and is an adult who's getting more than, 3 to 4 cold infections in a year without new or concerning exposure history. Like they don't have young kids, they're not traveling to places where they might be exposed to new viruses, they're not in a new work environment. For most people, I'm looking at secondary infections. So, somebody who really has immunocompromising condition or an immunodeficiency, it's not just viral infections that they might be at risk for. So I'm looking for, okay, are they getting colds, but then always getting a bacterial sinusitis or always getting a post-viral pneumonia, getting other infections that would make me more suspicious that there was something else going on.
Yeah, I was completely shocked. I don't know if you were, Molly, by how often little kids get sick. And that happened well into my being a doctor. I mean, it was like 12 a year. How is anybody supposed to work like this? But yeah, it's really rough. And I think at least sharing what the norm is can maybe help. It can feel less surprising.
Yeah, and it's hard for parents too, because the kid is better in 2 days and the parent's sick for 3 weeks. And it's like, how is this? how is this sustainable? But yeah, I think to your point, like it should get better. They should develop some immunity that they're probably in the worst of it when they're complaining about it. And hopefully next year or the year after won't be as bad.
Yes. And young children and adolescents tend to have rates of colds that are more similar to adults. So you can sometimes reassure the parents that, like, if they can get through that, kind of preschool age into like young kids are going to start to have less and less infections, and that should help the parents as well. Like everyone is going to get better immunity with time.
Well, did we cover everything with Mateo? I think we kind of talked about return precautions a bit. I guess the only other, if Mateo was older with medical problems, maybe you can list the medical problems you're paying attention to. How might your return precautions change?
Yeah, I think they're similar probably to some of the things that we mentioned earlier for thinking about like patients who you're more inclined to bring into the office on that initial evaluation. So certainly if somebody is pregnant, I'm definitely speaking with them and making sure that I'm feeling confident that it's, not influenza or COVID, and maybe that's just knowing seasonally that that's not happening. Anyone who's on an immunosuppressing medication or who has a severe chronic health condition. So I think of advanced kidney disease. I think of underlying chronic lung diseases, certainly ones that can be exacerbated by viral URIs. So thinking about COPD or people who have bronchiectasis or anything that might make me more concerned. People with underlying chronic heart disease, particularly things like heart failure, which also can be worsened by viral illnesses. Those are the people that I'm typically bringing into the office. And then I'm particularly worried about my elderly patients. I'm not bringing everyone in who's 65 and older, but certainly once patients are getting like 75 and older, I'm at least checking in with them. They're at least getting a phone call. And if their symptoms are progressing or lingering longer than that 5 to 7 days, I'm oftentimes trying to see them in the office just because I worry more about, even with viral infections, them having more severe symptoms from it.
Great. So I think this has been a great cover of viral upper respiratory infections that we'll see in adults in the clinic. And I think kind of to your point, within the first 5 to 7 days, if someone's healthy, generally doing okay, their vitals are all right, or they're not really out of breath, not having high fevers persistently, then we should feel comfortable recommending some of these over-the-counter medications and really trying to target specifically to their most bothersome symptoms. So just being comfortable with making recommendations around those. And then that really good patient education about when to come back, when would you need antibiotics, and when would we be worried about how your symptoms are changing.
I think we're about at the end. Before we finish, I wanted to ask about immunizations. Are there vaccines for the common cold that we should be telling our patients to get?
Yeah, probably not specifically for the common cold, but the vaccines that we think about most commonly are the RSV vaccine for older adults as one cause of the common cold for adults. And then certainly influenza vaccination, again, not for the common cold, but just for a mimic of the common colds.
Okay, so we definitely shouldn't forget about that, especially for higher risk patients in follow-up. We don't want that piece to get lost. Really to prevent COVID, influenza for everybody, and then RSV and Pneumovax for people that are older with higher risk medical conditions.
Yeah. I would say that I also wouldn't shy away from giving a vaccine, even if somebody did make it into your office with that common cold. I think sometimes it can feel kind of tough to convince somebody to get something that might make them not feel great. But the time when people are coming into the office with cold symptoms tends to be flu season, and it's a great opportunity to vaccinate people while they're in the office. And really, I think we should feel safe giving vaccinations to people with mild upper respiratory illnesses. And so I will actually use it as an opportunity. If nothing else, they might not leave with an antibiotic, but hopefully they'll leave with some protection against influenza.
That's such a good point. You might not see them for another year, so I don't want to waste that opportunity.
Yeah.
Well, Amber, do you have any key points or takeaways that you want to make sure to leave our listeners with? And maybe anything that you'd like to plug, either personally or some amazing resource on the topic of what we talked about?
Yeah, I think my main takeaway is just, again, what we started off with, which is common cold, viral, upper respiratory infection, doesn't matter what you call it. It really is benign, self-limited illness for the vast majority of adults. And we really should be thinking about conservative management. There are very little things that you can do to harm people when they have these types of infections other than inappropriately giving antibiotics. So my plug is just to really, as much time as it takes to really counsel, it's worth the investment in doing it and doing it consistently with your patient so that we're kind of minimizing unnecessary antibiotics. And I will say that the AAFP resource on management of common colds has a great overview of both over-the-counter and herbal kind of treatments and holistic remedies for common cold. And so if you're looking for a good overview, I think that is what I would recommend.
Well, thank you so much for joining us, Amber, sharing your expert tips. We really appreciate it.
Thanks so much for having me.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get weekly show notes in your inbox, including our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
We're committed to high-value, practice-changing knowledge, and to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps a lot when you subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts. A reminder that this and most episodes are available for CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. A special thanks to our writers and producers for this episode. That was us. Leah and Molly and Amber also helped to produce the episode, to write the episode as well, and to our whole Curbsiders team. Our technical production is done by the team at Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed the theme music. And with all of that, until next time, I've been Dr. Leah Witt.
And as always, I'm Dr. Molly Hoybline. Thank you.
Good night.